Well, let's get started. Welcome to SEVA VentRounds. Today is February 7th, 2023, and we're going to talk a little bit about patient ventilator discordance. And the topic for today is work shifting, which has gained a little bit more traction in what we should be focusing on. And we have some cool cases, some submitted all the way from Missouri, and it will be a nice discussion to be had. So let's get started. So the disclosures are we will discuss a lot of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinics. Your hosts are Rob Chatburn and myself, Eduardo Mireles, and you see there are conflicts of interest. So let's start by defining a little bit about what work shifting is. And what we have defined this as is when the P bend, so pressure from the ventilator and pressure from the patient effort, are active together. And so some portion of the total work is being done by the ventilator and some by the patient. And so this graph we have presented several times, but it highlights very nicely work shifting according to the mode. And so depending on the mode, you will have modes in which if the patient is paralyzed, so zero effort, the ventilator is going to be delivering this amount to overcome the elastic and resistive forces of the patient. But as the patient starts doing PMOS, so in the x axis you can see the patient effort. As the patient does more, the pressure that the ventilator will deliver will go down. And so that we see on the adaptive modes, adaptive targeting, so PCC-MBA, so PRVC, volume support, and volume control. The other relationship that we see is regardless of the pressure delivered by so the ventilator will deliver the P vent at the same level regardless of the amount of PMOS that the patient does. So if the patient does a lot of effort, the machine will continue to deliver or attempt to deliver that amount of inspiratory pressure. Now, as we have discussed many times, the ventilators are not perfect at delivering pressure, so it may be deformed or a little bit less, but it should continue to deliver or attempt to deliver the same pressure. And that's our classic pressure control and pressure support. And then finally, the proportional ones in which you have zero effort and the patient would die with no support. Well, the alarm would come in and start triggering. But otherwise, if the patient effort increases proportionally, the amount of P bend that would be delivered. I'll pause there for a second. Rob, any thoughts, comments on this graph?
No, it's very clear.
All right, so that's what the concept of work shifting is. And one of the challenges that you have is when you talk about work shifting is it good or is it bad? How much is good? How much is bad? And an area that we have been working a little bit more is how do we marry the term work shifting with the word assistance? And so work shifting is describing when PMOS and PVent are present. And in the center, you can see that there is evidence of assistance, but that means that in the two examples you have for volume control and pressure control, and also for the proportional, you can see that the pressure is above the baseline. There's the deformations or the changes that we describe when PMOS is present, but there's evidence of pressure above the baseline in all of these efforts. So the ventilator is generating assistance, whether the amount of assistance is appropriate, that's to be determined. But in general, this is the presence of both at the same time, coexisting. Not necessarily a bad thing, but it's happening. On the right side, you have under assistance, in which you have actually the pressure going below baseline. And that's a patient that essentially is getting no support from the ventilator. And this is an extreme case. There may be cases that are less in magnitude to this, but this is a term in which the PMOS is large enough and the PVent is lower below the baseline. And so we're under assisting the patient with the ventilator. And then you have over assistance, in which actually the support that we're providing to the patient is more than what the patient needs. And that's why we use the definition of it's unintentional minimal patient effort. And so you wanted there to be PMOS, but you're giving so much that the patient essentially triggers the ventilator, as you can see here on the EDI. And after that, the muscles shut down because the patient is getting as much or more than they need. So, Rob, comments?
Nope, looks good.
So I want you to start thinking under these circumstances as you're at the bedside, and we're going to put a couple of examples here uh, of work shifting in general. But this is how we're marrying work shifting with over and under assistance and assistance in general. So, and I see that Troy Whitaker is on the call, and he lended us this very nice case from Missouri University Hospital. And so, as we usually do, right now is the time which our team should use the chat and put in what is the tag, what is the load, and what is the main patient ventilator discordance that you see here. And like any graph, you have several breadths, and in each one is several things are happening. But just in general, what would be your patient ventilator discordance that you see here? If you want to type it in the chat, if there's one of the fellows that wants to give it a try and jump in and try to speak about it, you're more than welcome to do this. This is an actual patient, a real human. It exists. We'll give you a minute or so. And just start typing on the chat. What do you think is the tag? What do you think is the load? And what do you think is the patient ventilator discordance? All right, thank you, Hara. Hara is starting to put in some information. Test yourself, have no fear. This is the moment of truth. Okay, there you go. Oh, thank you, Troy. Welcome in. All righty, so let's get started. As more of the chat starts coming in, please just finish typing and we'll take a look. So the tag for this mode, at least as we are seeing it in this present slide, and there's more nuances to this ventilator in particular, but based on the waveforms, the four breaths that we have on the screen, these would be volume control. Volume control, and we know that because we can see beautifully the flow controlled during the inspiratory, and this will be CMB, so control mandatory because we don't see any spontaneous breaths, meaning pressure support breaths anywhere. And the tag, at least on these breaths that we have available here, would be an S, as many of you have recognized here. This ventilator does funky things, and it may have other things activated, but at least on these graphs, there's nothing activated. So this is the tag at this time. Rob?
Oh, that's good.
Alrighty. Then in terms of the load, Hara, we have several people that are talking about work shifting and what's happening here. So if we go on the first breath versus the second breath versus the third and fourth breath, and I'm gonna just name them here. If you see the first breath, you essentially can see the volume increases linearly, the flow, because the flow is linear. And then you can see that the pressure mostly, if anything, moves in a single line. If perhaps there is some concavity that may make us think that there is some recruitment at the end of the breath, but I don't see much PMOS there, at least inspiratory. So I would call this one a total passive breath. There's no trigger. There's no evidence of early cycle or any evidence of during the inspiration. So this one has no PMOS. And I would suspect, just by looking at it, that you can see how big the first step is from here to here. It's a huge step. And so that tells you that the load is mainly resistive. And actually, you can see how this is the changing pressure related to the flow is essentially flat. So I would call this that the load is going to be mainly resistive. And if I go and look at the expiratory waveform, you can see that it's not returning to baseline. And then there's this effort and perhaps, but the gain is not appropriately set. And so we can barely see if there is. So I would suspect that there is increased resistance for this, but that would be one of the hints. So remember, if you have one of these, it can help you. So I would say resistance is possible. And then you have on the second one, on the second breath, you have the presence of this deformation, and that makes me think that there is, because it's moving towards the baseline, that there is PMOS there. So there's evidence of PMOS there, and then you can see on the third breath that actually the pressure, instead of being all the way up here, is all the way down, and the breath was triggered, and we can see that there's the changing color. It's very small, but you can see it, and the same happens over here. There's triggering in both, and the pressure is much less than in this one that was passive. So that makes you think that the pressure has shifted, and this patient is doing effort in the third, at the end of the second, the third, and the fourth breath. And so I would say that there is, as Hara said, a lot of PMOS during inspiration in the second, third, and fourth. And then during exhalation, I can barely see a little bit here, and mainly a little bit here. I'm not entirely sure, but mainly it could be either resistive or some PMOS. Rob, thoughts there?
Yeah, that's all good. Right.
Okay. So if anything, what I would ask is, whenever you're seeing these waveforms, one thing to increase your ability to look at the expiratory waveform is just adjust the gain so that you're able to see this with better definition. That will help you, definitely. And so then we move to patient ventilator discordance. Let me see what people put. So they took the trigger as late, normal cycle, inspiration shows work shifting, triple triggering, and PMOS. All right. So let's take a look. So the first breath, we agree that there's no PMOS. I don't see any disagreement in the audience. So I'm going to say that this one is a passive breath until later on, but there's something there. In the second one, you have a mandatory breath, and then there's evidence of PMOS. And so that makes you think that this is a early trigger. So the second breath is an early trigger. The third breath it was triggered by the patient, at least by the ventilator. You can see that, as well as the fourth. And so, as Ariel said, the first one was passive. The second was triggered because of the PMOS started all the way here. So there's evidence of PMOS from here all the way actually to here. A very large amount of PMOS from here all the way to here. So this was an early trigger that triggered the next series of breaths. So that's the one that you grade. So the main discordance that you would say on this breath that you have here would be that there is an early trigger that started here and triggered all the rest of the breaths throughout. And so with that, the inspiration, you will see, well, there is evidence of work shifting on this. I have to change this. There is evidence of assistance or work shifting on these breaths, but because the cause is the early trigger, the thing that you have to treat on this breath here is the early trigger. Anything that happened afterward, you will agree that there was early cycle, but that doesn't matter. This doesn't matter because the cause is this one over here. And so the one that you have to treat is this one, and all the other ones will correct as you treat that. Now, during expiration, there is this little thingy here that caught my attention, and I'm just going to make it big for Rob. And you can see actually how the flow was coming down slowly and in exponential decay, and then it kind of accelerated. And it started dropping again. And so that made me think that maybe this patient had some expiratory effort. during that period of time that and you can see how it's moving away from the baseline as if the patient was bearing down at that time. And that made me think that there was increased resistance and that there was some degree of expiratory effort, but that's just like really focusing on that little area of work. And so I will stop there. Rob, what are your thoughts here?
Just to clarify why we call this an early trigger is because on that second breath, you have a machine trigger and then subsequent patient effort or a patient trigger. That's why we call it that.
So there's machine and then there's patient. And I know that this is in some of the literature, we are calling this a reverse trigger, but I would say that this could be many causes out there, and it could be that the patient woke up or yawned or had a deep breath because somebody squeezed his finger. I don't know. I mean, whatever you want. It's not necessarily the same pathogenesis that any reverse trigger, but it could be. This is just one screenshot that you're seeing right now.
Yeah, and this leads to multiple other problems, and you can list the synchronicities in order if you want, but essentially the initial one is the early trigger thing.
Right. Hara is highlighting in the drop in expiratory in the first breath. Could that have been a patient trying to trigger but failed? Yeah, that could be too, Hara. I don't see the it's the gain is so little that I cannot see if it's moving up and then down. And sometimes you can see that the patient took a breath in and out. So yes, I'm saying that there's increased resistance on this patient. And Troy was very kind, and in this image, I just hid it so that we could first look at the waveforms, and then look at actually at the EEG activity. And this was very interesting to me because there is evidence. I mean, in the waveforms, this is evidence of PMOS. And then you have this evidence of work shifting, and down here you have a very hyperactive diaphragm that, I mean, the waveform went somewhere all the way up here, and then it peaked down or looked like that, something like that. It got cut because the gain was out, but you can see that according to this image, the PMOS started over here, which is essentially around here, not over here. Which caught my attention. I mean, we have been discussing this behind in closed doors or in emails. That's better than closed doors, about the theology of it. And I'm going to show you another image in a second. But I wanted to bring it to the group. Is that because we're not the gain didn't capture that change over here, or another thought was, is there activation of other muscles before the diaphragm, which is kind of odd because usually they activate in tandem with the same behavior. So there's a discrepancy here between what you see here and what you see there. And Rob, what do you think?
Just to clarify, there is a NAVA catheter in this patient, but we are not in the NAVA mode. That's why you get the EDI signal. Because the catheter is being used to monitor the diaphragm activity, not to trigger and cycle inspiration.
True. Thank you, Rob. And this is certainly a very large effort. I mean, if you just count each one of these spikes down here is a second. So the inspiration for this patient, and if I assume that it ends around here, where I still see evidence of effort. Sorry, I was slouching, and that sabotages me. So 1 second, 2 seconds, 2.5 seconds of inspiration. So this is kind of a yawn of anything. It's a very large respiratory effort. And so there you go. Thoughts? Comments? Troy, you want to make any comments here?
No, not really. I appreciate what you folks are talking about. You know, I just know what I saw visually. It didn't look like there was any patient effort when I did an expiratory hold. We were looking for nasal flaring or any kind of abdominal movement. At least when we did the hold, we didn't recognize it. I do see what you're looking at, and in retrospect, I wish I would have changed the gain on a couple of those, especially in the flow, because it's so small we can't really tell.
Yeah.
Hey, Troy,
So
how
we
big was this patient? Like 300 ml tidal volume seems kind of small.
Yeah, they were worried because his airway pressures were high, but it was really all the airway collapse that this patient was experiencing. He had a stent in, but the other parts of his airway were collapsing, and I don't think I don't think the distal parts of the lung were seeing some of the pressure, but this was after they had deeply sedated him before we paralyzed him. We only paralyzed after this continued and the tremendous amount of air trapping that the patient was experiencing.
Thank you very much, Troy. Really a good image. And I'll show the next one because this one is another one. And actually, this has a little bit more information about a different tag for the ventilator. So in the sake of time, I mean, you can essentially, I want you to compare the past with here, and you can see that the patient is in a different PEEP. So they have increased the PEEP. I mean, and that's a classic good management of a tracheomalacia and tracheobronchiomalacia. You have to use higher PEEPs to try to control that. But you can see at very high PEEPs, the pressure that this patient is getting, even though the gain is all the way to 60, it's essentially flat. You don't see any support, but we know that this is volume control because we can see the flow waveform is being controlled. Now, this is the beauty of this waveform over here, is that you can see the change here on flow, and that only happens if the flow adaptation is the name, right, Rob?
Yes, and it depends. This is a servo eye ventilator. Older servo eyes imposed flow adaptation as a default. Newer software gives you the choice of the flow waveform.
And so it changes from volume control to pressure control, and that's what you're seeing here. The ventilator, it sensed that it was going to work shift. It was going to actually go into severe work shifting. Yeah, I don't know, Ariel. I don't know why they activated after, but it's a threshold that they have to go through, right? Three centimeters of water, I
Yes.
believe.
Yeah.
And then you have another breath that is delivered that now is a volume control breath. So this is BC IMB4 dual targeting. And during the inspiration, I only see PMOS as we saw before. And then during expiration, at least this piece of breath there's a lot of issues, but I don't see expiratory effort except over here perhaps. But you can actually see that the return to baseline now with the flow now really adjusted. You can easily see that it returns to baseline actually much better than in the prior one. So the resistance seems to have decreased on this model. And then in terms of PV discordance, I know this is hard to see, but this one is patient triggered. There's a change in color. This one is patient triggered. This one is patient triggered. This one I cannot say it was changing. So every breath has been patient triggered according to the changing color. And there's evidence of PMOS. So if you see this waveform, you would say this is being triggered by the patient, and there's work shifting. And it seems to be on time. So the ventilator is triggering as there's evidence of effort. Over here, I don't see other markers. So I would say that the trigger is normal, that there is under assistance. So this patient is getting no support from the ventilator, and at times it may be severe. I have to change this slide. This is a remnant of when I was practicing. And that the cycle, at least on this one, you can see how the cycle is, instead of having this nice decay that looks like this one over here, it's amputated. So this one is an early cycle, and this one, again, it's another early cycle because the ventilator cycled earlier. So you have two early cycles as a cause. So this is early cycling causing double triggering. And then no expiratory work, or I would call it normal. Rob?
Just a note that in this slide and the one before, the ventilator is displaying a tidal volume of less than 300, but in fact, the patient's getting 600 to 900
Correct.
when he's stacking these breaths.
Yeah, actually, on this one, the patient got 900. So
Yep.
in these three breaths, the patient got a high quality amount of 900, which means that the next exhalation, the waveform kept going below the screen.
Yep.
And on this one, you have 600 delivered with no alarm. And now the patient, if we allow them to exhale, should exhale 600.
Eduardo, one question. If we assume reverse triggering or early triggering on the second breath, what is causing the pressure to go down all the way if there is no P mask on the previous breath?
On this one?
On the first breath, I mean, do you think if we assume we only have reverse triggering, so that means
No,
that
no, this is not early triggering. All of them are triggered by the patient, Ariel.
Okay, that's what I was.
Yeah, no, this is all normal triggering. Actually, I'm amplifying so you can see it, and obviously the gain is very high here. So the dip is not evident enough, but you can see the dip and the changing color on each one of them, which is the marker that the ventilator tells us that it was the patient. And there's the corresponding drop in flow. Now, I'm going to show the waveform for the EDI, and this is what makes no sense, right? Because you have evidence of triggering with work shifting and no evidence of EDI. So absent EDI here, which tells you that something is off. It's either, and you have commented that is this other respiratory muscles triggering, but you have evidence of work shifting. So there's evidence of PMOS on each one of these breaths, and the EDI only gets activated on the last one, which actually, if you just looked at the EDI, you would say this is an early trigger, but by looking at the pressure waveforms and the morphology, this looks and feels like that there's PMOS involved there. And so the question here, and we need to do more into looking more into it, is, I mean, how can it be that there is activation of other respiratory muscles, so probably the chest wall, without activation of the diaphragm, and then suddenly the diaphragm activates? I mean, the level of dysfunction of the respiratory center is huge to have the muscles discoordinated, if that makes sense. This is a arrhythmia of the respiratory muscle activation, in which the chest wall activates first and then the diaphragm, when usually there's a progression of the signal because it comes from the bulbar region, right? So it caught my attention, definitely. Rob?
I have seen one patient on NAVA that was showing no EDI signal, but was triggering the ventilator. And that was because the patient had a known diaphragmatic paralysis and they were triggering with accessory muscles. So it can happen.
Yeah, that could, I mean, that's another thought, right? So evidently the catheter, and this is one of those images that I would like Cinderby to talk a little bit more on what is happening here, or what he has seen, is if you have, because this is using the crura from the diaphragm. So is there partial injury, or there's desynchrony because one crura is not present or paralyzed and not transmitting, the other one is? And so there's pendeluft and discordance in the activation of the chest wall muscles. It's very, very, very intriguing. All right, it's 2:31. We didn't get to the last case, but I'm gonna just show it for the viewers to have a take on it, and we can revisit it next in our next bend rounds. But this is a very nice, another case that has an EDI monitor and gives you some information regarding what's going on. All righty. With that, we have some good news for all our respiratory therapists on the call. And our next vent rounds, we will be able to offer how do you call this, Rob? CRCs?
Continuing respiratory care education units, CRC.
And those will be available for all of you that are respiratory therapists that want to spread the word. They come for free and they're high quality. And as well as we are working on doing this for our physicians. You can get the CME applying for the CCF. So thank you very much. Thank you to all for attending, and hope you learn. And Troy, thank you for letting us share this high quality case from your location. All right. Have a good one.